No, I am not going to introduce our panelists. I'm going to let them introduce themselves. But I do think that we'll use that time wisely. While you're introducing yourself, if you would share just a little bit about what virtual nursing is in your organization, just kind of a definition of what it means for your organization, because I know that it means different things to different people and different organizations, and that'll kind of get us all on the same page. And so either one of you can start.
Good afternoon. Thank you for sticking it out to the end. We appreciate it. It's good to see all these faces. My name is Dr. Pamela Agrabish. I am the VP of Telehealth at locumtenens.com and LT Telehealth. Our company designs telehealth programs from the ground up. We also are one of the largest staffing firms in the country. So we place doctors, nurse practitioners, PAs, and PhD-trained psychologists all over the country, both in hybrid programs, telehealth programs, and boots-on-ground opportunities. For us, virtual nursing, we have an arm that also specializes in nursing. But for us, virtual nursing is the crux of how we staff programs. If nurses don't believe in the program or don't buy in, we all know that they do not succeed. So for me, it's very, very important to have very happy nurses, whether they be the employees of the current client that we're servicing or the nurses that we're delivering. That the programs that we deliver are nursing based, they have buy-in, and that it's more of a collaborative approach.
Great, thank you. My name's Ashley VonNida. Have my doctorate in nursing practice. I'm the Chief Nursing Officer at Equum Medical. We're a telehealth company from door to discharge. We provide sitters, RNs, physicians across the continuum. And virtual nursing to me is a supplement of your current staffing. It is a nurse who can be a resource, and for each hospital that we work with, they're very different based on the hospital need and the KPIs that are being measured. So for us, we provide experienced nurses to help supplement your current staff.
Hello, Sarah Bell, Nurse Administrator at Mayo Clinic for Virtual Care Nursing. A little bit about our scope of virtual care. We have 143 EICU beds across the Midwest and Florida campuses. We have about 404 inpatient virtual nursing beds with a plan to get up to 800 very soon. That's our newest service line in the inpatient setting. We have had 23,000 patients through our remote patient monitoring program, and one of our newer offerings is our home hospital program, which has seen about 2,000 patients. To me, virtual nurse is somebody who works virtually and supports all these programs. Probably more what we're going to talk about today is VERN, or virtual RN, and that is, I believe, where we are going to change the way we provide nursing care. We have not changed our model of care in decades, and now we are at a crisis, an inflection point where we have no choice. And virtual nursing is going to be what propels us into the future. It's going to be a new means to retain, recruit, and keep our nurses working at the bedside in virtual care. And I think it's also a way to, it's going to change the way we mentor and support our new nurses away from that traditional model of my preceptor's right at my side. My preceptor can be virtually now too.
My name is Troy Leo. I'm a cardiologist at Atrium Health. My role is Senior Medical Director, Virtual Health for our system. So like Sarah, we're a big healthcare system, and so I would say our offerings in virtual nursing are very similar, where it's EICU nursing, hospital at home. I think specifically probably we'll talk to a little bit more is what we call our virtual nursing, which is our VNO program, which is the kind of inpatient floor adjunct nursing. And so it's been a really successful program for all the reasons I think that have been mentioned today. And I think, when I think of virtual nursing, it's really the theme most of us have heard all conference, which is, telehealth is health, right? So virtual nursing is nursing. It's not a different, it's not a different segment. It just is nursing, and we're going to deliver it in a new way that we haven't, for all the reasons we'll probably talk about, and you've heard, for all the reasons we're doing telehealth. It's been really successful. We're going to continue to expand our operations. for the reasons that we all need to, which is staffing and finances. Unless you all are at systems that are unlike mine, we're in the red just like everyone else, and we're trying to figure out solutions to continue to deliver great care in the real situations that we're facing.
Thank you. So coming from a large academic medical center, I know how difficult it can be to get the buy-in that you need for novel programs. I'd like for you to share a little bit about how you obtained that buy-in from the leadership. What were the things that you were answering, by suggesting or implementing virtual nursing?
So we go in and we said, so I don't work for just one system. We go in and we are contracted by many, many systems across the country to come in and build programs on all different kinds of scales in 160 different specialty lines. So I wear a lot of hats. But what is always consistent about virtual nursing is process, procedure, and sustainability. That is the key to making sure that the programs run efficiently, that was the key to getting buy-in, in my opinion, when I was speaking to executive teams and then also to, chief medical officers, chief nursing officers. Can I reproduce it, especially if I have a multi-system organization where, right, you've got the mothership and then you have a lot of maybe rural or smaller clinics that need to follow behind. So it's great that you can do the program, but can you keep doing it consistently? And again, can you get the buy-in from the nursing staff to want to do it? And then from the patients, are they feeling that the nurse is still very present and a part of their care? So we ensure that those are all met, and I believe that that's why we've been successful.
I would say the same thing. People and process. We're big change management people. We, like Cotter, we have that guiding coalition, and if that's the executive team and they have financial issues or staffing issues, then we want to address that. But we take it a step further, and so for virtual nursing, we use their shared governance model, the actual unit that the pilot will be on or that the unit will have the virtual nurse. We bring all of them together and say, what's working well for you? If you could change any 1, 2, 3 things, what would it be, and how could we make it better for you? And then we take that back and have quick wins. So they see the value of it, we measure it, we fix it, we repeat it, and then we roll it out across the organization, and that is huge for buy-in.
I would say that for us at Mayo, it had been more about the people. So needs of the patient comes first, but needs of the care team members come first. We started in COVID. 2020, providing a non-EICU virtual nursing service offering, and it spoke for itself in staff satisfaction. Overwhelming satisfaction. And so what we're doing is building an infrastructure that then can provide scalability and ultimately improve patient outcomes. We already have very good patient outcomes. So we weren't coming out of the door saying we're going to reduce length of stay and mortality. We were meeting a lot of those metrics already. Our goal was to come in and not change those. How do we fully change the model of care and not change anything? And how do we create a process that the nurses and the bedside care teams can interact with the virtual nurse in a seamless way? And then we will get to the product side, adding wearables, adding stethoscopes so the virtual nurse can assess more, and doing more remote assessments. But our first part and our main goal right now is preserving bed capacity in our rural hospitals and clinics throughout the Midwest. I don't know about you guys, but if you're from a small town, people aren't coming out of nursing school wishing to live in rural Minnesota, where population's 300. It's just not the market, right? So how do we maintain access for patients in those communities and not shut down beds because we're not staffed? Well, we have to provide a virtual offering that can help preserve bed capacity. So that's how I speak to the CFOs. I can keep your beds open. We can bring expertise to your areas. And then for the nurses, it sells itself. An environment where they can work a hybrid model of care. I am a nurse. I can work at the bedside some days. I can work in virtual nursing some days. And they're reinvigorated and excited and happy, which in COVID, we've not been happy. Nurses are leaving the profession in droves. This is going to help us bring some stability to our workforce, and it has. So we're measuring patient satisfaction, staff satisfaction, and our outcomes. And over time, we'll get there, but it's slow. You can't go fast in this space. You can go fast, but if you don't design it right and design an infrastructure, you could have issues later on as you're trying to overhaul something that maybe came out the door too fast.
So when I thought about how to answer this question about how to get buy-in, the most honest answer I can give you is have a pandemic. Because that's really how I got buy-in, right? You know, we didn't have enough nurses, we didn't have enough PPE, so I joke, it's like when I go home, I'm the cook in my family, and so when I make dinner for my wife, if I told her I'm gonna make mac and cheese and like, you know, she would look at me like, that's what we're having for dinner. But if I came into a house that had nothing except a box of mac and cheese and we hadn't eaten in 7 days, it'd be like, that mac and cheese looks amazing. Right? And that's where we were, right? And so that's really how we started the VNO program. We had a pretty robust, you know, ICU virtual program, but really for this, it was, we don't have a choice to do it. And we were lucky, I'll say, in that we had that nidus to be able to show what we thought was going to happen, which is all the benefits everyone here has talked about. And now we can say, let's expand it, because the next crisis that all of us have is staffing, right? So for retention purposes, for all of you that are trying to hire, you know, just like Sarah said, rural North Carolina is not that much better than rural Minnesota. It's a little bit warmer. So actually, if you want to come, you should come our way. And so the play now to the CFO is look at all the money we're spending in travelers, look at all the money we're spending in trying to hire people, look at all that. We can show you, we can retain our nurses. So many of our nurses that said, I was thinking about retiring, I'm going to do it now. Or there are other nurses that are having physical issues. We can say, well, let's lessen this physical burden on you. And so we were lucky to kind of have the pandemic to show success, and now we can use it. My tip of advice for you is you don't need to have the pandemic to show that it works. Sarah's got amazing evidence of what she's done and her program has done. Use that to solve the problems, right? So you don't have to do that first step, and just use the kind of successes that you've heard for and will hear the rest of the day to tell your teams, this is why we need to do it.
So all of you brought up some great points. One of the things that I think we need to bring out here is the fact that each organization that you work with has a different problem. I mean, some of the problems are common among the organizations, but, you know, one may have an issue with staffing, one may have an issue with, you know, just you have the staff there, but there's something else, there's a problem that you're trying to address. Sarah mentioned that they were already meeting their metrics, but there are some organizations that they're not meeting, you know, their metrics. So I would like for you to share I want Sarah to share a little bit more about the phrase she used when she said they were changing their model. So share with us what was the impetus for that, and then a little bit more detail about how your virtual nursing program works.
Sure, happy to, thank you. So in 2020, we stood up virtual nursing, no better time than in a pandemic to try and do something creative and new. We started, our impetus was an influx of inexperienced new grad nurses, and like, they're like, what do I do? And we had very experienced nurses that there wasn't enough of them to partner up to precept to do all of that. So I was involved in starting our EICU and was like, we should do EICU light, and now it's virtual RN, but it's bringing our experienced nurses virtually to be there. And we started with one virtual nurse to 100 patients and looked at that model. We started with about 150 beds in our medical area that was getting just killed by COVID. Very busy, lots of PPE use, a lot of high turnover in staffing. So we started there. And then what we did was we tracked our data. We looked at staff satisfaction, we looked at patient satisfaction, we tracked our metrics. And what we noticed is that on the units we were supporting, we had reasonable staff satisfaction, but not really high. And the reason for that is they felt like the virtual nurse was inconsistently available. 100 patients is a lot. It's hard to be everywhere. And so what we did is we pivoted. And now our model today, and I can say today because that's the beauty of virtual nursing, is it can always change. It's malleable to whatever your needs are. Now we have one virtual nurse to 50 patients. We hesitated to go smaller than that because we have staffing shortages. And so I can't get today to one nurse to 15 patients. But what I want to do is one nurse to 50 patients. They have a medical unit and a surgical unit, so they have offsetting flows. And we focus on 3 high priority things that come above all else: admission, discharge, patient ed. Because we're in the middle of a tech, we were crafty in the beginning and used iPads. We can't do a lot of remote assessments with iPads, so we needed to pick the tasks that could be done on an iPad, and kind of be scrappy with it. We're transitioning to Caregility, so on the next, and we're getting a little more assessment focused with that. But then what we've done is scaled now, and we're measuring again staff satisfaction, patient satisfaction, watching outcomes. What we're noticing now is a really high degree of patient satisfaction. They're discharging by a virtual nurse, and they're satisfied with it. They felt like they got everything they needed. Our patient satisfaction scores have gone up. And units that are supported by a virtual nurse, because we have more time to go through that patient ed. There's not call lights going off. My phone's not ringing. My pager's not going off. I'm not worried about everything else. So the patients are getting a really good discharge experience. The bedside nurses are satisfied because now we're able to do over 80 to 90% of admissions and discharges for them, consistently available. We stagger our shifts. We're busier 11 a.m. to about 4 or 5 p.m. So I have heavier staffing from that 11 to 7 p.m. shift. I have 24/7 staffing, but I can lighten up at night. So being really data-driven and always evaluating and looking at how we're doing it and where we need to go. And I can say that's where we're at today. Next iteration is getting into more assessment capability and moving differently. I think as nurses, sometimes we shy away from technology and think, I'll just scale down my staffing to make it more robust. But what we're trying to do in partnership with our Center for Digital Health is say, what tech can we enable that's going to make the nurse's job easier? And how can we do it without more work? I say to them all the time, my job, I don't want you to do more work. I want us to make your work easier and bring in solutions that aren't disjointed and funnel us down different ways. So.
Thank you. Troy, I'd like for you to answer that same question too.
So I'll go into a little bit of details for us, because I think the biggest thing to know is what Sarah said is this process is very malleable, right? So we are not where we started. We started off in a COVID med-surg unit, again, because of the PPE issue. So now, as we've evolved this, we are changing vendors, but we have been able to do assessments. So a lot of our work, again, is admission, discharge, but we do assessments, do ins and outs. We actually have helped with codes. One of the really helpful things you can do is, for that nurse, when a code or rapid response happens, there's always someone that says, hey, what just happened with this patient? Someone look in the chart, right? Well, that's really hard for the chaos that's going on in the code physically, but the virtual nurse is a perfect person to be able to look at all that stuff and then communicate to the team some of the backstory of what's been happening. We're currently at I'm going to have to change how we do stuff. We're currently at a 1 to 10 and a 1 to 20 ratio, depending on what we're doing. And we have 24/7 coverage for that. But again, I think things have evolved all along this. I know we're going to talk about KPIs, so I won't get into too much, but similar stuff we're looking at. We saw patient satisfaction go up. We saw staff satisfaction go up. We saw, as you heard earlier, 2 hours less of putting on and taking off PPE. So not only the monetary cost of having to buy the supplies, but also just the time cost of having to do that, we're able to save. I think the biggest thing that I think about is, in some ways it's like, oh, well, it's a hospital and patients that you're seeing. I'll say for us, but I'm pretty sure it's for everyone here and a lot of you out there. The patients we're seeing now in the hospital are are sicker than we used to see. Partially because we're doing great telehealth. So we're getting rid of patients from the hospital, and the ones that used to be there aren't there anymore. And so we've kind of cherry picked the less sick people, and we're pushing them out. So everyone that's in your floor bed was maybe a progressive patient 5 years ago. And everyone that's a progressive patient is probably an ICU patient now. And everyone who is an ICU patient was probably sent off to a tertiary or quaternary care center, right? And so if you think about that, your staff didn't change. And so now your staff has more stuff to do than they did before. So we can say, well, the nursing ratio didn't change. It's still 1 to whatever, but their patient got sicker. The stuff that they need to do is much more complex. So how can you take that away from them, right? So that's what we do with our virtual nursing. It's not to replace anything, but if you think about it, we added like 4 things onto all of our nurses' trays by the complexity of the patients that they had. And what we're using virtual nursing for is to say, well, let's help offload all that stuff that they had to do. Because I can tell my wife's a nurse practitioner, my sister-in-law and mother-in-law are nurses. So while I'm a lazy physician, they're the hardworking ones in the family. They'll tell you it's a lot harder than it used to be. And so we can't just keep doing the same things that we used to do. And I think this is our tool to say, well, we're going to start taking some of the stuff that you don't need to do physically at the bedside, because there's always going to be stuff that needs to be done at the bedside. It's never going to go away. It should never go away. But this is our tool to do that.
Thank you. So Ashley and Pamela, I have a different question for you, because I know that you're in a different role. You know, you're a different position, kind of on the outside of the health system, and they're coming to you and asking you to come in and help. So what are the things that they are, when they approach you, when they reach out, what are they saying is their problem? Do they know they need virtual nursing? Or do they just present the problem and then you're like, okay, here's what I have to offer you? And then after you begin working with them, how do you connect with their nurses that are already there? You know, I know when we were, and this was in our own organization, we were doing tele-ICU, the nurses in the ICU felt like we were Big Brother. Like we were coming in to watch them and, you know, to be critical of what they were doing, and like they weren't doing a good enough job, that kind of thing. Do you experience that? And, you know, just how do you make that connection?
Absolutely. So a lot of times when I get brought in, I have a little coined term. I'm called the fixer. So if you're reaching out to me, a lot of times things have gone sideways, and that's okay. A lot of times what I find is that someone mirrored a program, right? They're like, I heard Mayo speak, I heard Hopkins speak, and I want to do that. And not every hospital has the same resources. Not every hospital looks the same, and that's okay. A big piece about tele, and what I have tried to, I think, encourage especially the last couple of years, is your program needs to look like what it's supposed to for your facility, for your clinic. It has to work for your culture, for your people, for your staff. And so I think that's a big piece of this, right? So we do a lot of tailoring. When I go in and start to look at how can we streamline process, procedure, how can you be more efficient with the current staff you have? If I need to augment your staffing plan, how can I do that affordably, appropriately, and most likely virtually? I think probably all of us can say, especially those of us that are providers, before the pandemic, and I don't know however else, I have never been able to work virtual a day in my life. So I never had work-life balance. My husband and my children can tell you that. I probably still don't. I'm trying. But I think that this COVID did do a lot of things, right? It accelerated telehealth significantly, but it also was eye-opening to the fact of we can try to restore work-life balance to people who are exhausted, really want to give back and support their community, and we can keep them in healthcare. Sarah was saying, right, they're leaving in droves. Troy said, you know, he definitely is seeing that on his side too. I think that if you can structure the program properly and speak to your nurses, and they want to be a part of it. And the last piece I'll say is when we go in, many times, it's really interesting, the first meeting I'll have is structured with no one who's medical. It's all with the executive teams, which is great, right? I get that your finance officer needs to know how much this is going to cost. I understand that your president needs to but that's not who I need in that room. Who I need in that room are the people who are going to be dealing with the virtual system, right? I need to talk to your nurses. I need to speak to everyone on the floor, your chief nursing officer, whoever's in charge of those units. I need to speak to the doctors who are rounding and who are, trying to get things done. So the other piece I will say is that when we are sort of the pushback, or if we have problems, it's because we're not talking to the right people. And we need to make sure that the folks that are going to be using the program and who we're building the program for are the ones that are in the room when we design it. Because I have to design it so that it works for them. And so therefore, again, what I design for Duke or Hopkins or USC or whoever, it will never ever look the same, because no health system is the same, right? So whatever you do, make sure you design it for your people.
I would say when they come to us, they have a problem. They might not say we need virtual nursing, but we need help. We can't staff at night, or we can't staff this unit, or we now have telehealth and we have sicker patients and we don't know what to do with them, or we've had poor outcomes. So increased in CAUTIs and CLAPSIs, and there's just no bodies. So again, working with that guiding coalition to say, okay, we can solve this. This is how we can do it. If that's augmenting your current staffing. I will say the number one thing that we do, it's not just throwing another nurse at the problem. It's really digging down the layers of the onion as to why you had that problem. Process redesign and making sure that we are all on the same team. We have pods, so it's not like a 1-800 number and you get random nurse of the day. They know exactly who's working on their pod. They know who the physician is. They know the bedside nurses. The bedside nurses know our nurses. We know all the policies and procedures. So it's just an extension of the team. It's not us and them, it's our team. So I think we've done a really good job with that from the very beginning to say, we understand your problem, this is the solution, and this is how we're going to achieve it together.
So I've heard each of you actually mention staffing as one of the problems that they come to you with. And I think that sometimes there's a misconception, that they can hire fewer nurses if you are there. I know that nurses at the bedside get a little anxious. When we talk about bringing in people virtually, they think, okay, my job is in jeopardy. And then on the other hand, you have hospital leadership, for example, saying, well, this virtual nursing program has not helped me because I'm still having to hire all these nurses. So they see it as an additional cost. So can you all explain your experience with that, or if you have experienced that at all, where they felt like it was not beneficial to them because their bottom line was the same or more? And what kind of value do you bring? Like, how do you explain that to them? I know sometimes for us, it's not that you're going to have to hire fewer nurses, but it may be that you're paying fewer penalties in some way. So can you explain just a little bit? Just give us one example, each of you.
So I will say you have to show the ROI, and time is money. So if you're looking at flow, that's a big one for us. A lot of people come to us and say their RER is backed up, they're still sitting here. So if a virtual nurse can pull them through your system and decrease your admit to room time by 200 minutes,
That's a lot.
That's a lot. We know the length of stays are going up. So if a virtual nurse can get your discharges truly out the door by 11, we all know that's our goal. If you really get them out by 11, so when the ER is busy from that witching hour of 11 to 11, they now have space. And so if you can show that ROI, that's your win. While, yes, you're still going to have a nurse, you're never going to eliminate nursing. You're never going to eliminate bedside nursing. But decrease your length of stay, improve your flow and throughput, you got it.
And patient satisfaction, I can't stress that enough. I don't know how many of you've gotten surveys after you've been in the hospital or been somewhere, right? And how was your experience and what? We're making it better. These programs absolutely make patients feel better, feel more cared for. I think we're more expeditious with our processes. On top of that, they do have choices when they seek care. And I think that's another big piece of this, right? So you kind of go back to what is the ROI? The ROI is, I had a great experience when I went through, it was really streamlined this time. I was there maybe 3 months ago, and it took me, right, I was supposed to get discharged. I called my family. My daughter took off work, and I didn't get out till 5 p.m., right? Not to mention the bed flow crisis that was happening the other way. But we're changing that. So we're making things, again, more streamlined, and the patients remember that, and when they have a choice, and then they're able to also recommend the system to other people, right? Those are all really powerful things, and sometimes they take time to measure. And I think that's probably the other thing is, please give me time to collect the data that I need to show you that the program is appropriate and will work. I cannot produce that data for you in 4 weeks. So give me the appropriate amount of time to collect data, streamline it, and also survey your staff. Is your staff happier? Are you now keeping them? Are they not leaving? There's so many different ways to show that this is really working other than just money.
What is an appropriate timeline? So if someone is
It's the
saying,
magic question.
did you know that was coming? But seriously though, as I think about, groups that may be saying, we're going to do a virtual nursing program and we're going to try this for 6 months, or we're going to try this, what's reasonable?
I think 4 to 6 months is fair. I will tell you that it takes 3 months to work out the bugs, okay? Borderline. And then I would say we're probably cooking from the 3 to 6 month mark, but my best data probably comes in between 6 and 9. So just because usually we're getting the most patients right through, everybody really feels comfortable. We've probably gotten through most of the training. If we had people that started the program and then dropped out, and I'm talking about nursing staff. So yeah, I would say probably the sweet spot is somewhere between 4 and 8 months. So how the rest of you feel?
Well, first of all, we know that the reason we're not getting our patients out before 11 is because our physicians aren't writing the orders fast enough. Just kidding.
Doctors are the worst.
I do want to say that we've taken a different approach, and I don't think. One, I think it's dangerous to say that you're going to need less nurses because you have a virtual nursing program. Okay, we already don't have enough nurses. Don't even make that value proposition. It's not worth it. Where the money is do you know how much it costs to turn over a nurse? Over $30,000. And if you can retain staff by doing this program, you've saved hand over fist in dollars. Tons. This provides that retention that we all need. We need experience to stay at the bedside. We need a sustainable workforce. This is it. It's not, you're going to need less nurses at the bedside. You'll be able to staff at a 1 nurse to 7 patient ratio. Those are the wrong metrics, and those are going to set us up for failure as virtual nurses. We can't do that. That's dangerous. It really is in the retention, the creating a sustainable workforce that people want to stay in. Our nurses come off orientation, and I'm sure you guys are all doing this too. We're like, how fast can we get this nurse off orientation? Like 6 weeks? Like we used to do 12 weeks? Can we cut that in half? We got to get them off. And then we get them off, and then they don't have the support and resources that they need, and then an event happens. And they're like, I don't want to be a nurse anymore. I want to quit. That was over $30,000 out the door because they didn't have the resources to do it. So I think that's the value proposition we're seeing in the retention. We're making that case over and over again. Again, the case isn't I'm going to save lives or change the way we're doing things or have shorter length of stay or things like that. We'll get there. We just started. I want to get my patients out faster on remote patient monitoring where my other virtual nurses can go. Stay stable, stabilize your workforce. I have a different, I want a very scalable program that could be vanilla and boring if you're looking at it, but it's going to be really efficient. So high value things, admission, discharge, patient education, really, really good at it. Allow tools, AI, other things to tell me when a patient's deteriorating. I don't want them flipping through Epic and looking at, screens of vital signs. I want a solution to tell me that. I want my physical nurses to be exactly where they need to be when they need to be there, and that's when they're going to be fulfilled. And I think that's a very important value proposition.
So I can't stress enough what Sarah said, that if I could tell you one thing that you remember of this whole thing, don't try to sell virtual nursing as the way to lessen your ratios and lessen the amount of physical nurses that you have. It's the wrong answer. It take like 2 days to talk through that. But what I would say is, when we're talking to, our finance people and position committees and everything, there's a lot of really good benefits of virtual nursing programs. And I would use them for the story part of it. And so what I would say from that is like, so what we saw was our patient satisfaction went up. And I think the biggest reason the feedback we heard is from, I don't know about you all, but you go into a hospital and everyone's wearing a mask, right? And so the patients only see people with masks on. And this was the first person they actually got to interact with for significant times and saw their face. And so we use that story a lot because people can resonate with that. But I'll tell you, don't really, my advice would be not to use patient satisfaction, discharge times, length of stay as your KPIs for this, because there's so many confounding variables, right? It's really hard to prove actually that VNO programs did that, because maybe it was one of the 18 other things we're trying to do to make discharges go out quicker or length of stay shorter. And what you don't want to do is hang your hat on one of those things and then it get worse because of something that happened, right? So really think about what you can control, and I think that's why I would piggyback on what Sarah's saying. This is about nursing, and so really stick to, this is about staff retention. How much does it cost to replace staff? How much does it cost to hire a staff, to recruit a staff? I don't know any places in the country that are not having staffing problems from the nursing point, so I can just say everyone's having it. And so if you stick with that, you can prove benefit much easier than you can if you're trying to use those other KPIs.
So Troy, you kind of led into my next question. I think we know that patient satisfaction, nurse satisfaction, all of those are things that we need to measure throughout here. But if you all could share two or three metrics that are just, you must measure this, or to present to the hospital system or the group, that this is what we're going to measure and this is our measure of success. What would those things be? And you might have already said those things, but I want you to mention them now so they kind of stay on the minds of the people in the room.
It's really hard to only think of
That's
two.
it.
I mean, I would say staff satisfaction, staff retention, cost of labor. Those have to be at the top of every proposal you're talking about. There's a whole bunch of other things we talk about. I think somebody already talked about our call alarms went down, and you can use those as your secondary things to tell the story. But when it comes to measuring the stuff, I'd stick to the first ones.
Totally agree. Staff satisfaction is huge. I'm sure with the current healthcare environment, our staff satisfaction scores took a major hit. This is a way to bring them back up, to reinvigorate teams. So staff satisfaction, I would say, to your point, people like working in virtual care. I can get nurses to pick up in virtual care way easier than coming to the unit. So it's another means to have people working as nurses, and so we're able, our goal, it's early, I want to reduce my incentive pays. So how do I impact my incentive pay? Because it is an incentive to work in virtual care. They like it. It's easier to pick up and do that. So we're kind of looking at it from that angle. I'm sure most are paying incentives in this room or using travel nurses, and those costs are high. So cost of labor would be my other one as well.
Same. We do staff satisfaction, turnover percentage before, during, and after. And length of stay on a unit, not patient-wise, but staff-wise, because we all know med-surg nurses jet.
That's true.
They turn over just as fast as a position opens somewhere else. So if you can keep those experienced nurses to help grow the next generation of novice nurses, that's important. And then we do measure throughput, so discharge times and throughput, especially if that's what they come to us for. And the other one that we do measure a lot are those quality indicators. So Claudius Clapsies, if you come to me and you've had 10, we want none. So.
I agree with everything they've all said. To take it sort of in a different vein, because I know we keep sort of talking about inpatient, right? It's kind of where this is rotating. And I do a lot of outpatient. And so I think a big piece when we look at virtual nursing is also access. When we're able to, especially I look at diabetes programs, right? We have so many diabetics that just need access to diabetic educators and nurses. I can't even tell you. And now that we've put them virtual, that has been a game changer, right? Access for these patients to keep them out of the ED, to maybe even keep them out of the primary care's office, or to make it a conduit. So I think just on a different vein, and you're making, I think you are putting a whole generation of nurses that are looking to work differently, and they want that high touch but high tech opportunity. I just think there's just no downside here. So, how do we make it the most advantageous that we can to incentivize the workforce, to make them want to stay, and then also to make it better for patients? And I just think that the word access just keeps coming back.
Right. So. Right. Options for our workforce, I think, is what I'm hearing. So do either of you have anything that you're just burning to share with the group before we move into questions?
Ooh, I'm going to hit one topic that I've heard a lot about since I've been here that's just burning, and it's the concept that virtual nurses can't work from home. I don't know why we're saying that. Why can other practices have people work from home and provide virtual care, but our nurses have to be in a physical center somewhere to provide care? Think about it. If you have just exploded your recruitment capability if you allow work from home. Your catchment area is anywhere. That is crazy. You're going to be able to retain the best, keep the best, even if they're going through a life circumstance that's going to move them across the country. I want my good nurses to stay. I don't want them to move across country because their husband's moving and they're going to do a different job. So to me, we can't let one, I don't even know if horror story or whatever, be like, that's why the nurses can't work from home. They're just going to they're going to watch Netflix and chill. No. But I will say this, that we do have to be good stewards, right? So we have to measure productivity. Why wouldn't we measure productivity? We measure it. I measure their productivity. That's okay. They know I'm measuring their productivity. And if you're not meeting my productivity, then we're going to have you come into the call center and work because you need probably a little more mentorship and help. And when that's the situation, your productivity goes through the roof at home. And so I just want to, let's not box ourselves in. We're so early in this. Why are we boxing ourselves in? So that's my burning platform.
I could not agree more because my 25 years ago, I'm dating myself a little bit, but when I was first starting in critical care, was moving into, Troy's laughing because he knows, and I did my first sort of like tele ICU assignment. We had a bunker. We thought we were so cool, right? I walked into the hospital. I was part of the bunker. There's screens everywhere. All the docs and NPs are all together. It was very exciting. And I heard actually the speaker prior to us say that she actually just developed a program and she's doing a bunker mentality. I'm not saying it's wrong. I'm just saying it's limiting. The whole purpose of tele is to be remote. And so if you then say, well, you're virtual, I'm going to put you behind a screen, but you still got to come to campus. Why would I do that? I might as well just come to campus and work. So I could not agree more. Be very careful about how you structure your programs. I promise you can reach out to any one of us and we can tell you the guardrails to put around your virtual folks at home, right? You have to be in a proper office. We're happy to supply you the equipment that has all the proper security parameters. I got my tech guy right here. He can tell you what it is, okay? So there's all kinds of rules, regulations, things that you can do that are really easy to make your people successful from home and from anywhere. And as Sarah said, if you've got that stellar ICU nurse and all of a sudden she has a family emergency, something happens and she needs to move, why do you want to lose her, right? So just think about how you box yourself in. It's exactly right.
All right, thank you.
So I had to share, because I know on these panels it seems like everything for the people up here is always perfect. I want to share how we failed. So, our first unit, I told you, was med-surg COVID. It went great. Everyone loved it. So we said, all right, unit 2, here we go. And we were like, this is going to be awesome. Everyone's going to love it. And we did it. And they were like, cool. And they didn't use it at all. And what we didn't realize was we did a really poor job in a few ways of, one, realizing the needs that we were able to give, they actually had tools to do. Right. So they actually had discharge coordinators to do a lot of the education. And so the stuff we were saying, hey, we're going to do all this stuff. They were like, we don't need you to do that stuff. And they kind of looked at us crooked. Eventually, we started communicating the things that our program could do, and now they love it. But I'll tell you, the first few months of that, we were like, let's look back at our stats. And we're like, oh my gosh, they don't use us at all. So be very smart about, one, the places you're going to do this in, because not every place actually needs it, or not every place needs the scale of what you're doing or the skills of what you're doing. We made that mistake because we just thought worked well here, it's going to work well there. And then make sure you're really communicating what you can offer and what the tool you have can offer for everyone. Because I think once they understood it better, they started using it, but we did not do a good job of communicating that. So I know the three of them will not tell you any failures because they haven't had any, but we have had ours.
Oh, yeah, lots of them. So we do have time for a couple of questions. Is anyone, there's one?
I'm on my way. Julie Miller from AACN. I'm one of the things that you just mentioned were the guardrails you put in place to protect the people at home, and then the productivity measures that you do to measure. And I'd just like to have you both expand on that a little bit more.
So just similar, you have to be in a private room. You can't be at the kitchen with your kids like after school. So you have to be in a private room. We provide the equipment similar as you, so we know it's safe. It's within our firewall. They're working off VPN, so they're still kind of remoted into our Mayo workstation. And then from productivity, we're just getting there. We transition our RPM team over. We're working on how to get our virtual nursing team into this as well. But we use some systems that record everything they're doing on the desktop. So if a patient complains or if something's going on, we're going to go back and listen to that call. We're going to see what they were browsing or doing while they were on that call. Also allows us to train. So if it takes her 10 minutes to admit a patient and it only takes me 5, well, I could go in and watch how she's admitting a patient and say, well, we could have cut this corner and done that different and whatever. And it kind of provides that mentorship capability. And then there were some great vendors here, which is just some next level things that we're going to think about, in the voice standardization protocol space that I'm excited to kind of move into, but we're really early into this.
I think the only thing I'd add is that I think the contract for the nurse that is virtual does need to look a little bit different. I think we're like, oh, contracts and nurses, we don't really think about that. But I think when you're going to do a virtual opportunity, that's where you can build in some of those guardrails, right? You will follow the following, and you're going to sign this, and it's a legal document. And if you break it, here's kind of what the process is. I think the other piece of this is that we don't want to appear like Big Brother, right? I'm going to ping your computer every day to make sure you're in the country, and I'm sorry to tell you that sometimes that's necessary, because people will jot off to the islands and not tell you, and you're like, that's a beautiful background. Is that virtual? Is that real? And you laugh, but people, it happens.
That's just northern Minnesota that they're.
So I think that those are things, but I think that you can also look at sort of on the front end, right? You front load it with when you hire folks. Listen, this is a really great opportunity, but there's a lot of rules. And here's the rules you have to follow, and I'm going to need you to sign on the dotted line. So.
Any other questions?
Do you have a dedicated IT person who is supporting this, works hand in glove? I've been there. I've been a virtual nurse since 2006. And that was one of the big issues. I'm in the middle of a, encounter or seeing something, and something happens. Oh, they pushed a piece of software. Oh, they did this. And you have to get it done in that immediate time. And that
Correct.
was always a big barrier for some nursing. Is that something that's built into your models?
When we deploy, we ensure that there are systems set up, and so whether we run it or the hospital or the clinic run it, we say you have to have at minimum the following technological backups. So, and then there's a couple of different things, right? If it's directly affecting patient care, you're not queued right into a queue, you're immediately taken to somebody. If it is, I can't chart, but it's not directly affecting patient care, well, you're going to leave a message and we're going to call you back. So yes, there's definitely those pieces. Does it work perfect every time? No, it's tech. If anyone has phones or watches or whatever and stuff glitches, we glitch. So no, it's not always perfect, but I do think that you can build appropriate backups. And I think also patients, right? All those disclaimers when they say it's a telehealth visit and whatever, they do need to know that. I will tell you this, if you are a provider or a nurse and you're on the other side of that camera and all of a sudden the screen goes black and you think no one can hear you, I promise you they can.
They can.
This is a plug for the non-bunker style because that's how we buffer outages, right? So if my Florida campus is having a hurricane, which is why I don't live in Florida, then my Midwest team will take that work on. My Arizona team, if they're down, that's how we buffer shortages and things across. But if you don't have a product team, a team focused on product and tech, that's a big miss because I rely on them a lot to make it run smooth.
And redundancy. We have a redundant station set up for every client just in case. If this happens, then this. If there's a storm, tornado, whatever, we build those safeties on the front end.
That's good to know. They weren't there when I started back in 2000.
We've gotten better.
The other question is, how much of an impact, as you do these models, do you think having a piece of technology in nursing curriculum would help, or would it not? I mean, I've been a professor, and I tried that, and was shut down many times, and then COVID came. And everything they didn't want to do, it was like, no, you're going to have to do. And unfortunately, they lost 3 faculty members. They just took their retirement. They're out of the problem. So it's an ongoing problem. How would that impact these models if you had nurses that already doesn't have to be extensive, but some knowledge through their curriculum?
I would say COVID helped that. The nursing schools, clinical programs, everybody's embracing technology and learning how to use it and use it wisely. And it's proven to improve outcomes, engagement with staff, NCLEX pass rates. I mean, there is definitely an opportunity in nursing for tech to expand our life.
I think that the exposure is good anyway. They may not ever work in that world, but that more will come out and have already seen it and at least know that it exists. And then we'll probably find those that kind of go in that direction, which is good because they're still helping us. And then those that hate it, can stay away from it, but they will have been exposed to it. We are out of time. I'm sorry to cut you off, but we are out of time. So I'm sure that either of these panelists will be happy to answer any questions you have, but we have to move for the next group. So thank you all for your time and sharing your expertise.